Just to introduce Sopany, she's a research fellow at the Centre for Health Economics Research and Evaluation at the University of Technology, Sydney. And in her role there, she's really a key member of the team which conducts evaluations for the Pharmaceutical Benefits Advisory Committee and also the Medical Services Advisory Committee, as well as doing commissioned research for various government and different stakeholder groups. So she's currently completing her PhD in modelling the cost effectiveness of end-stage heart failure using discrete event simulation. And today she's presenting on some work which didn't form part of her PhD, but she did during her PhD, looking at the real-world cost effectiveness of folic acid fortification of bread flour in Australia. And this was work which, as Sarah mentioned, won the 2019 Early Career Researcher Best Paper Award from the Health Services Research Association of Australia and New Zealand last year. So Sopany will talk now. Feel free to put questions as she goes through in the Q&A section or in the chat function, preferably questions about the content in Q&A and technical issues in the chat. And I'll hand over to Sopany now, and then I'll come back at the end and moderate the discussion. Thanks, Sopany.
All right. Thanks, Sarah and Alison, for the introduction. I really appreciate it, and thank you for giving me the opportunity to present my research, which I'm really excited to do. I just want to apologize in advance if my Wi-Fi cuts out, and if that happens, just let me know. So as mentioned, I will be presenting a study that I did called the Real World Cost Effectiveness of Mandatory Folic Acid Fortification of Bread Making Flour in Australia. And as mentioned, I work at CHERE. So this particular paper was published last year in Applied Health Economics and Health Policy. So if you did want to have a look at it, you can very easily find it online. Before I continue, I just wanted to thank my co-authors for helping me on this paper. So that's Phil Haywood, Naomi van der Linden, Kathleen Manapis, Elena Misharakova, and Stephen Goodall. The structure of today's presentation, I'll just be going through the whole paper, so the background, introduction, methods, results, and discussion. So to start, many other countries do already have food fortification programs, and really the intention is to provide additional nutrients to foods that make up a large kind of staple part of the community's diet. So common vehicles include flour, rice, maize, which is a kind of a corn flour. And the background of this particular research was that we were commissioned, CHERE was commissioned by the Australian Health Ministers Advisory Council to conduct an evaluation after the mandatory folic acid fortification standard or food standard was implemented in 2009. So when we came on to do the evaluation, this was a required evaluation, and CHERE put in a tender to win that work. So prior to 2009, there were voluntary fortification programs available. So certain millers and bread makers would market their food as being fortified with folate. But it wasn't a mandatory standard. And we also relied on women who were planning on conceiving to be educated through, the midwives and the doctors to potentially take supplements and to eat folate-rich foods. And so those were the suite of policies or strategies that were available to reduce neurotube defects, which I'll explain a lot more about later, prior to the mandatory food standard. And in 2009, it was determined that that it should be mandatory. So what that meant was flour millers were required to fortify their wheat flour with adequate amounts of folic acid, and then bakers were required to use that fortified flour. There were exemptions, to this food standard. So if you were a producer that provided, say, organic bread products or unleavened bread products, you didn't need to fortify your bread with folic acid. So the consumers did have kind of options to have folic acid fortified food products or not. And this research is, one of the things I wanted to highlight about this research is economic evaluation was conducted after the program had been implemented. So we relied on real world data to estimate how good the program was and how cost effective the program was. And I just wanted to highlight that this is different to when you do an economic evaluation before a program is implemented. So this is an ex post program evaluation. So what are neuro-2 defects? Obviously, the reason why this standard introduced was to reduce the number of neuro-2 tube defects. It's a congenital condition. It affects the spine, spinal cord, and brain. So essentially, without enough folate, the spinal column doesn't form properly. And as you can imagine, that can lead to long-term health concerns for babies who are born with those conditions. The most common of the conditions is spina bifida. And spina bifida is the severity of where the lesion is, so where the spine doesn't form correctly, will determine the severity of the location of the lesion will determine the severity of the condition. So even someone with spina bifida might, a group of people might have spina bifida, but they might have different, physical or mental impairments. Another one, less common, is encephalocele, which is also a neuro-2 defect. And then the third one is anencephaly. This particular birth defect means that the newborn is, so the infant is born without a skull, and this particular condition is not compatible with life. So it's not listed there because there's no long-term care because the infant won't survive. The reason why sufficient folate, I mentioned why sufficient folate is important, but what's important is to actually, women need to have enough folate in their system pre-conception. So if you've ever seen, say, an Elevate ad on the TV, you will know that you're supposed to take 3 months before you're planning on conceiving. So you actually need enough folate in your system before you even conceive. And as we know, not all births or not all pregnancies are planned. So the reason why the mandatory fortification program was implemented is because because not all pregnancies are planned, we can't rely on supplements and even the advice to eat folate-rich foods in pregnant women. One of the things that has been noticed is that there had been an annual decline in the number of NTD affected, so NTD neuro-2 defects, that's the terminology I'll use throughout. NTD affected births. There has been a decline from around 1989 to 2008 before the program was implemented, and I'll talk about how we. So that would be a combination of all the voluntary fortification and education about eating folate-rich foods. That would be the impact of those programs in play, and I'll talk about how we kind of address that in the modeling later on. And one of the other reasons why the mandatory program was implemented or was needed as well is because NTDs, the rate of NTDs did not affect the population evenly. There were definitely higher rates in children born to mothers under the age of 18, as well as to Aboriginal and Torres Strait Islander mothers as well. So that can give you an idea of why the program was important, or is important. So the model that we built was a decision tree model. We did a pre-post analysis. So the pre part is the pre-mandatory fortification, so anything before 2009, and the post part was 2009 and onwards. The model was built in Triage Pro, which is a typical kind of software package that you can use to build models. We chose a societal perspective because, so typically when you do build models, you might decide to focus on a healthcare perspective. We chose a societal perspective because there were clear long-term kind of obviously healthcare costs to babies born with spina bifida or encephalocele, but also longer-term impacts on on the carers, as well as potential productivity loss as well for people living with these impairments. And we chose a lifetime horizon for the model. But the focus of the population that we focused on were really women of childbearing age, which is women 16 to 44 years of age, which makes up around 20% of the population. And within that population, so 20% of the Australian population, around 6% would be pregnant. And the outcomes or the patient flow that I was really quite interested in, so, pre and post, women of childbearing age, whether or not they were pregnant, like I said, 6%. We split the women into different age bands because we had, I'll talk about the data sources, but the rate of NTTs are different between different age bands. And if pregnancy was affected by a neurotube defect, again, I mentioned there were 3 types: anencephaly, encephalocele, and spina bifida. And the outcomes that could occur per NTT affected pregnancy could be a termination of pregnancy. So this is when the condition is picked up early and the parents decide to terminate the birth. But also the birth could continue, and it could either result in a stillbirth or the infant could be born alive. And then this was further split into neonatal death and neonatal survivors. So the difference between the two is the 28-day survival rate. So survivor would live beyond the 28 days. Yes, that's the structure of the model. Next, I'll briefly go through the model inputs. So we relied on the Australian Bureau of Statistics data for the demographics. So that included, the net proportion of women of childbearing age and where they sat in each of the age bands. And what we relied on for the effectiveness of the intervention was we had really rich data on the birth prevalence of neurotube defects from most of the states around Australia, states and territories around Australia and New Zealand by the different age groups, which also explained why we chose that particular structure as well. And the data came, we separated the data into different kind of time periods. So as I mentioned before, we relied on a pre-post analysis where the pre-2009, that's our comparator or control arm. And then our post-intervention were the rates that occurred or the births that occurred after 2009. So we were given really great data on the rates by the different age groups, and obviously we had to convert these to probabilities, and then we applied the odds ratios between to find the difference between the two time periods. I wanted to mention as well that because previously I had mentioned that there was a background trend in the improvement or reduction in NTDs anyway from 1998 to when the program was officially introduced, we did take that into account in the scenario analysis, and I'll talk about the impact of that later. One of this particular source is not something that was used in the model, but helped support the model. So with any nutrition program or nutrition intervention, to attribute, reductions in cases of NTDs or improvements in quality of life from reductions in NTDs, there needs to be a link between the improvement, so the program itself, and the health benefit. And what Food Standards Australia and New Zealand, what they had done is they had provided data on the dietary intake of a population survey, looking at the dietary intake of folic acid from pre-mandatory fortification up until 2014. So that demonstrated that there was an improvement, an increase in the amount of folic acid in people's diets, and particularly in women of childbearing age. So that was good evidence to support that there was more folic acid in the bread that was consumed by the population that made its way into their bodies. So that provided that kind of link, because again, we're looking at so without having to rely on that surrogate outcome, we could be sure that the reductions in NTD were linked to that increase in dietary intake. I'll next go through, so as I was talking about before, this is a cost effectiveness analysis. So we're looking at quality adjusted life years. And actually what I'll do is I'll first go through the different outcomes that we looked at, and then the different values that we used to come up with those estimates. So we have utility values for the mothers, as well as for the babies. As you can see here, the quality of life for a baby born with encephalocele is just slightly lower than for spina bifida, so 0.45 compared to 0.55. For the life years, we assumed that for the mothers that there was no difference, even if, there was no difference, it was 84 life years. And then undiscounted, the difference between the 20, or should be 20 and 18, is we assume that if was an NTD affected birth, the 2 years later, parents are likely to have another pregnancy. So there would just be a delay in the pregnancy. So there would be actually no change in family size. And that was one of our assumptions. For the baby born with as a stillbirth or as a neonatal death, there was no life years gained. And for children born with encephalocele or spina bifida, again, there was just a 1 year difference between the two, with encephalocele just being a bit worse off. And also we looked at a natural unit of neurotube defect cases avoided as well. So with the cost, all costs were in Australian dollars in 2014. We have, as you can see here, a few types of costs. So the cost of delivering the intervention, so the fortification cost, this was provided to us post-program by the industry and by the government. So with the industry, this includes flour millers, as well as the bakers. For the government, this included the cost of monitoring whether or not there was enough folic acid in the bread that was being sold. And then these costs were split between per person and then the upfront implementation cost. So I will refer to those as startup costs. We had healthcare costs, which were the cost of the birth admission, as well as the the lifetime healthcare cost, and this included inpatient admissions as well as outpatient visits, assistive technology. So those three would be considered more healthcare related costs and the cost of the intervention. So for the societal perspective, we included care time cost and productivity loss as well. So we did a fair few sensitivity analysis. So we did univariate sensitivity analyses on all the rates of the TTs as well as the probabilities that determined how patients kind of flowed through the decision tree model and the utility values. We also conducted a probabilistic sensitivity. So the univariate sensitivity analysis was used to determine the uncertainty within the parameters that we had applied in the model. The probabilistic sensitivity analysis was used to look at the uncertainty within the joint, so the joint parameter uncertainty across all of them. And we applied beta distributions for probabilities and gamma distributions for cost. And we ran that for 10,000 iterations. We also did a number of scenario analysis, which I had briefly spoken about earlier. And these were to see how, these were to test the main kind of structural assumptions that we made in the model. So one was to take into the background rate, and the impact of that was that reduced the number of incremental neurotube defects avoided. To apply a disutility for termination of pregnancy or stillbirth. So in the base model, we assume that there's no disutility, that it didn't affect your quality of life if you had a termination of pregnancy or stillbirth. And also to include the startup cost. So remember, this model was conducted post implementation already. So our base case model didn't include the startup costs because they were already they had already been implemented. But we did do a scenario analysis to see what it would look like if there was a version of reality where the program was reversed and then implemented again. And obviously that increased the incremental cost. So these are the major findings. So the base case, which are kind of represented in the blue circles, the incremental benefit of the program was that there were 32 fewer entity-affected pregnancies, and this equated to around 293 quality-adjusted life years gained. The incremental cost was a reduction of $1.5 million, excuse me. And the ISA was, so because there were more benefits and fewer costs, the mandatory fortification strategy ended up being the dominant strategy. So it ended up producing health benefits as well as reducing costs. And so that's our base case scenario. So when we looked at a number of scenario analysis to see what the impact would be on the ISA, on some of the structural assumptions that we had made. So as mentioned, if you had included the background rate of the reductions, there would be, instead of 32 fewer entity-affected pregnancies, there would be 14. However, the ISA remained dominant. Again, with the inclusion of the utility loss, it would improve the quality adjusted life years gained. Where there are differences were if we only looked at the healthcare perspective, so not the societal perspective, the incremental cost would be an additional $100,000. So that would not be a saving as such. But the ISA was $373 per quality gained. So it would still be under what a perceived threshold, willingness to pay threshold might be. And if the government had decided to not include, so to reintroduce the program, this would cost $2 million. So an incremental cost of $2 million, and the ISA would go up to 7,000 per quality gain. So again, you know, it would still be quite cost effective. These are the results of the univariate sensitivity analysis presented as a tornado diagram. So, and on the left-hand side, you will see all the different parameters that we tested, and in the brackets, you'll see the lower confidence interval and the upper confidence interval. At the top here, you'll see the ISA per colleague gained, and you can see the base case, again, because it's negative, it was because it's dominant, so it's health producing and cost reducing as well. But what I wanted to highlight were the main drivers. So you can see anything at the top of the tornado diagram would be considered one of the main drivers. So these included obviously the rates of NTDs in the age groups, inclusion of the cost of CHERE, and the productivity cost as well. So those were the main drivers. Based on our base case scenario, we did the probabilistic sensitivity analysis, which looks at the joint parameter uncertainty. So if we assumed a willingness to pay threshold of $50,000, which again is in Australia, there is no distinct willingness to pay threshold, but just as a guide, the post-mandatory fortification program, so that's a willingness to pay of 500,000. The blue line here indicates that based on the 10,000 iterations, post-mandatory fortification, so the current program would be considered cost-effective compared to the pre-mandatory fortification. And then finally, looking at the discussion, so we determined that mandatory folic acid fortification was both effective and highly cost-effective. So previous to the introduction of the program, there had been a number of other studies. So Food Standards had done modeling to determine what the impact of the program might be, and they had modeled around a band of 14 to 49 NTDs reduced per year, and ours was 32, so we're pretty happy with that. It was within the bounds. I also wanted to highlight that there were previous economic evaluations conducted within the Australian context as well, and our estimates were quite similar to those two studies as well, which was really good. One of the things I wanted to also highlight was, again, this is a population-based program, so it should, and one of the aims was to reduce the inequities of the distribution of NTDs. And as you can see, the two groups that that really benefited from the program were those children born to Aboriginal and Torres Strait Islander mothers, as well as teenage mothers as well. So in 2017, the report was endorsed by the Australian Health Ministers Advisory Council, and they determined that, you know, based on our report and amongst other reports as well, that the program should continue. And that's it.
Great, thanks so much, Sopany. That was really interesting. So if anyone has any questions for Sopany, either points of clarification or you'd like her to expand on something, then you can just type a question in the Q&A section of the Zoom screen. So if you go down to the bottom of your screen, a little menu should pop up and there's a Q&A button there that you can click, and you can write any questions that you have, or you can use the chat function as well. But I guess just while we're waiting for people to type their questions, Sopany, the way you present it, it seems like the data was all there really neat and tidy and you had everything that you needed. But I wonder was there anything about the data that was available, or if you could do the model again in an ideal world, what would you change? You know, was there some better data that you would have liked to include that you couldn't?
So with the data on the neurotube defects rates from all the different, from the different states and territories, we did have issues where I think South Australia, we didn't have it from South Australia or Tasmania, and New South Wales, the data from New South Wales was actually underreported. So I didn't present it here, but in a scenario analysis, when we try to account for that. So I think more complete data from all of Australia would have been really useful, but given the data that we had, I think it was pretty good.
Yeah, okay. And then we've had a question from Janet McDonald saying, is fortification of flour alone sufficient, or are there other food products that we should be considering also fortifying to give us better coverage across the population?
Yeah, so as I mentioned before, Australia focused on the fortification of bread making flour because dietary studies from ages ago indicated that bread was one of the staples that people in Australia tend to eat. But also I mentioned in other countries they do like rice or corn. So I know in a lot of South American countries they do the maize because that's one of their staples. So it really is kind of dependent on I guess the country and what they tend to eat as well. But in terms of the adequate dosage, the amount that's in there should be sufficient, but the recommendation is that women who are pregnant should still eat folate-rich foods like spinach and if you can afford it, supplements as well.
Mm-hmm. Okay. And I guess that actually ties in really nicely to another question I had, which was, do you know how many other countries around the world have implemented something similar? And if you were a sort of policymaker, I guess, in a country that was looking at implementing this, because when you included the startup costs, it does come at an additional cost, although it has an additional benefit. What are some of the things that you think those policymakers should be thinking about?
I think, so I know Canada also has a program, as well as the US, where they have fortification programs. The upfront, so it's interesting because the upfront cost is borne to industry typically. So they would need to pay for the equipment that adds the folic acid to the flour, as well as the cost of labeling their products to say that there is folic acid in their products as well. So I guess it just depends on, I guess the cost is borne by industry and government because the government has to monitor it, but the benefits kind of are for, you know, the healthcare sector as well as even the education sector, even potential you know, productivity gains as well for parents who don't have to take care of a very sick child, and also for someone who, you know, can avoid spina bifida so they can earn as much. It's kind of tough because it's unlike a typical, because it's a public health program, unlike a typical, say, drug where the cost of providing it is, you know, borne by the government who purchases that drug, which is kind of the field that I'm a bit more familiar with. Public health programs are interesting because they do affect kind of other industries that you wouldn't typically think about. So here it would be, you know, the food industry, but it's a public health program. It's something that would, you know, really help a lot of lives. Yeah, I think that really is interesting, and also the idea that you can impact equity on the basis of a program which you roll out at the population level, so everyone benefits, but you do have some subgroups of the population who might benefit more than others. So we didn't have any other questions coming through, but we might just give people a couple of minutes just in case there were some last minute questions. While we do that, I can see that Sarah has popped up the webinar satisfaction survey. So if people have any other questions, please feel free just to write them in the chat function or the Q&A section of Zoom. But otherwise, it would be really great if you could
go through the quick survey. I think it's only about 5 questions, just to give us some feedback about the webinar. The Health Services Research Association, as Sarah said, tries to run the webinars monthly, and we're really keen to make sure that the topics are interesting and that people are getting a lot out of them. So any feedback you can give us would be great.